Um, Thank you for having me. So yes, my name is Michael Page. I'm the Director of AI Commercialization at Unity Health Toronto. That is a hospital network based out of Toronto, Canada. My lab is about 30 people, and we are one of the most sort of prolific AI groups in in at least the country, having deployed many solutions into clinical practice. So my background or my focus is on translating these tools that we're building and using every day in clinical care and clinical practice to get them to be used in other health systems and by other clinicians. So I focus kind of on the tail end of how can we scale these things and how can we see greater benefit across the health system. So looking forward to today's discussion, and thanks for the warm introduction.
Right, that's great. Okay, now let's move on to our next speaker. Omar, can you introduce yourself and tell me a little bit more about your background?
Sure. So my name is Omar Costela Reyes. I'm a researcher currently at MIT. I'm in the computer science department. So we do research on neurosymbolic AI, which is it's a hybrid model of neural networks and symbolic systems. And my interest in the lab is to apply those techniques to healthcare. So we come with the motivation of making AI tools in anything in the clinic that has to be used with AI more transparent, explainable, and verifiable to be able to deploy these tools safely in the clinic. So I'm pretty much interested in that area of impact and have projects and papers in there. And also I'm currently speaking out a company for chronic disease management using those tools specifically for GLP-1. So I'm very excited to have an impact on also chronic disease management and produce real world products. So we're speaking out this company from MIT as well. So that's a short story of my research and also what I'm doing today.
All right, that's great. And then can we have Soroush? Can you sort of introduce yourself and talk a little bit more about your background?
Yeah, of course. Thanks for having me. I'm Soroush Saghafian. I'm a faculty member here at Harvard. I'm also founder and director of a lab here at Harvard called Public Impact Analytics Science Lab. So we do lots of AI development and AI work for different aspects of healthcare. Some are on decision making, some are on operations of the hospital, some are on health policy, and some other aspects of healthcare as well. We work a lot with hospitals, so we have projects with different hospitals, with different healthcare systems, both nationally and internationally, and we try to develop AI tools that can have an impact on the practices and outcomes for the patients. So lots of AI work. I also teach a course at Harvard on machine learning and big data, and we cover lots of different materials on how AI works and how machine learning works and related things and their applications.
Okay, that's great. All right, with that, I think we'll move on to our questions. So, Michael, in your publications on AI-driven healthcare solutions, you discuss optimizing patient care while reducing healthcare costs. What do you see as the biggest barriers to scaling these solutions across various healthcare systems?
Yeah, easy question to kick us off, right? So my background, I was doing a lot of consulting and seeing kind of how AI was being used across industries. And I think now working specifically in healthcare, some of my advice or some of the consulting I do is we're probably not as unique as we like to make ourselves out to be. And maybe the easy things would be over the last few months that you would comment on, like, oh, the cost is prohibitive, or regulation seems to be even more opaque and confusing than it has ever been before. But sitting back, and I think that the chief issue that you're sort of getting at is what's holding us back from seeing AI proliferate. What's holding us back from these tools that Omar, Soroush, and myself are building, how come we're really not seeing those scale? I have a part-time appointment at Western University at Ivy Business School, and kind of our view and our analysis is this really has to do with organizational capability. So if we really step back and we zoom out and we look at Soroush or Omar, myself, our groups have incredible capabilities. They're really well educated, hopefully decently funded. But if you go to more the applied side into your average community hospital, that same capability is not there. You won't have the same level of data engineering. You won't have the same level of data science capability. And then where you really see this start to break down, and part of our thesis or part of our argument is AI is truly a team sport. You just won't see the same capabilities within your IT function. You won't have the kind of resources or understanding within HR or legal or privacy or security. So that foundational layer, if we really think of the foundations of digital absorptive capacity, these foundations of what build out an organization's capability are absent in many parts of the healthcare system. So what do we do? How are we trying to solve this? We try and train and educate a little bit more. But from a system or from a provider perspective, where things are quite challenging is the system can't really perfect itself. So what we're doing, and I'm glad to hear Omar's doing some of this work, is how do we start translating some of these inventions and some of these things into companies that can really help maybe speed up the adoption process for the health system? Because Soroush is doing good work where he's introducing this into curriculum. A lot of medical schools, a lot of nursing schools do not have this as part of core curricula. And we're really seeing this being quite absent from the health system writ large.
All right. That was like pretty good insights, on AI and healthcare. And to sort of kick us off with this topic, Omar and Soroush, do you have any comments or any questions or any follow-up questions to ask Michael? Or
No, I just wanted to also elaborate on the
yeah,
the AI in healthcare. Right? So everyone is excited today to apply AI in healthcare, and unfortunately, it doesn't have much success. It's more buzz than reality. And the main drawback and the main problem is that the systems that we have today in AI are very unreliable, right? So everyone is using language models, and language models are this black box that you never know what you're going to get out. And these are big problems in healthcare, right? Because if you get the wrong answer, you might cause harm, right? So we need to be very careful on that. But we're making progress, right? So there is some tools, for example, this ambient AI that is being used in clinics a lot today. That is not decision making, but it's still helping in tasks to help clinicians, manage their interactions with patients, be more optimized in how they spend their time. Because
yeah,
believe it or not, the problem of a physician is not that they they are seeing a lot of patients. The problem is that they are asked a lot of documentation, and burnout happens because of the EHR and all the systems. So we could simplify that. It could help a lot. So we're moving in that direction, but we're not still ready for any clinical decision support tools because it's very unreliable today. Even the FDA approved tools that exist today, I've seen that they fail in certain cases. So I believe we are very early stage, but there is other tasks that we could have an impact.
Yeah, and so I also wanted to build on the discussion a little bit and emphasize two specific issues that we found in our work that are sort of the barriers. One is what we call it algorithm aversion, is the fact that physicians, because they are dealing with lawsuits and a lot of they have to make high stake decisions, they tend to not rely on algorithms and not sort of trust the algorithms. And even if they have, and when we give them this AI tools, they try to, at the end of the day, go by their sort of experience and intuition, even if they know that the AI is working better and making, correct predictions or correct decisions. But a more major barrier when it comes to high-tech decision making, things like, healthcare decision making that the physicians have to deal with, not just the documentation and things like that, which are easier, but when it comes to actual decision making and deciding whether, for a complex patient, they should give this treatment or that treatment, algorithms are not there yet. So we have what are called causal aversion, which is the fact that all of these AI tools are mainly built based on, sort of the association that you have between different variables, and they don't have the ability to make causal sort of decision making, where you need to understand what is causing what in the body of the patient, or in lots of variables that is available when you get, you train them over EHR systems. So on the research side also, we haven't worked much on making, this tools suitable for practices by teaching them how to do complex causal reasoning, as opposed to just relying on, associations. And what LLMs do is all at the layer of association, nothing much at the layer of causation that we actually need if you want to have real impact at at practices. And so some of the work we are doing in my lab, or like on moving these LLMs or other AI tools to a layer that they can understand causation, and that they can provide new treatment recommendations for patients.
Yes, that's absolutely correct. And I had another question for you, Soroush, and that is that your research at the intersection of operations and analytics is aimed at enhancing public sector performance, so particularly in healthcare. So where do you see sort of the biggest operational roadblocks in contemporary healthcare systems, and in what ways can, data-driven methods help to overcome these hurdles?
Yeah, so healthcare systems deal with lots of operational issues. And, if you ever go to an ER and you end up waiting for hours and hours over to your physician, and despite having an appointment, you have to wait there for many, many hours, you realize that there is lots of operational mistakes that happens, and largely because of limited capacity, but also because we have not learned well how to manage limited capacity that is available. And so lots of work needs to be done on improving the operations of the hospital, as well as the decision making of the physicians, right? Even if you do best decisions, but it's not timely, and you have to, excuse me, make the patients wait for a long time, and you're not able to see them on time, that's not going to be effective. And a lot of patients actually die because we are not able to, treat them in a timely manner, even if we know that, the best treatment for them. So that's where, AI can also help a lot, is that, try to use the limited resources that are available. We have limited time of the physicians, we have limited beds available in hospitals, we have limited nurses, we have limited, test facilities and things like that, that all of them need to be utilized by patients to be able to, provide them with the best service. But how do you use those limited, resources in the best way, is where AI can help a lot, right? And that's where I think, AI can influence.
Yeah, that's correct. Omar and Michael, did you have any follow-up questions or any added comments to this, about how AI can, conquer these operational roadblocks?
Well, I just want to add to the causality part. So I think that the healthcare is super challenging because, at the same time we're trying to build these AIs, we also don't know much about the human body, believe it or not. So we are pretty early stage in understanding how we work, right, as a system. For example, I'm doing research on GLP-1s, right? We don't know the extent of what these drugs do to the human body, right? So we're still running clinical trials, and this is just one example, right, of how we it's very hard to characterize ourselves, right, all the way from the brain to how our immune system works. So we have to deal with that, and then try to build tools that help people, right? So it's double challenging. And we also have this shortage of nurses and staff that and it creates burnout. So you have many problems, but I feel that if we are allowed to innovate, right? Because that's another problem. There's too many startups or many projects that don't get the impact because in my opinion, I feel that the power is very concentrated in certain players, insurances, and so I think there should be more innovation, more competition.
Yeah.
But there's many problems, but I think that step by step we could just try to make progress.
Yeah.
Yeah, these are great, absolutely great points. Soroush has taken us to like the many process problems, and worth noting that like healthcare is human, and we're talking about people at the end of the day, and there's absolutely limitations in the technology, but one of the biggest barriers of where we're seeing failure is not the algorithm itself, but possibly like how are we bringing people along in this process. And at some point we realize maybe we try to solve the wrong problem that actually clinicians don't really care about at all, but just algorithmically we can get there. And so what I'd say is like a big part of our work is how do you engage, how do you bring your clinical team along with you, and what does that process look like? So just a bit of insight, like our lab, we don't have data scientists walking around the hospital trying to find problems to solve. We've set it up as a service center where clinicians come to us. So we have doctors and nurses coming to our lab pretty much every week saying, oh, would the data we have be able to solve this problem? Or I really hate this part of my job. Can you fix it? And this simple way of kind of approaching our innovation process is bringing people along with us. But to some of the parts that Soroush is getting at, like that's where we're really understanding like what is the intervention that we should be getting towards, and is that something that we can actually solve, and is that something that AI should be doing at all? So really insightful points from both Soroush and Omar on this. Absolutely.
Yes, I definitely agree on that. And then, Omar, I had a question for you that, your research focuses on spatiotemporal pattern recognition for healthcare and security applications. So how can machine learning models be effectively trained and validated using real-world healthcare sensor data, given the complexities of, privacy and data variability?
Well, we have tried to figure out that question for many years. Yeah, it's a good question. So first, let me explain why we were doing that in the first place.
Yeah.
So the motivation of that research is that most of the researchers today in AI and health, or any health data scientist, focus on the EHR, right? So the electronic health record. And I'm very happy that there is new initiatives that try to standardize the EHR and made available to researchers, like the Ai-Labz database that exists. So I'm very happy to see those efforts. But I believe that those are still clinical data points that are incomplete, right? So we're not still telling the full story of the patient, right? So what you see in the EHR is just 15 minutes appointments that the patients have with the doctor, right? And I don't blame them, right? So there is no staff, as I mentioned before. So well, they will have spending more time, and there is this episodic, data points that we have of clinical data. But I'm interested in chronic disease, right? So chronic disease is an evolving disease in time that is social. It has to do with mental health. It has to do with how you eat. It has to do
Yeah.
with exercise. So all this other contextual information is not captured, right? And therefore it affects our understanding and the way we attack these problems, right? Because I also believe that we need to evolve from the point of view of medication, right? So if you go to the doctor, they are trained to give you medication, right? So any problem you have, they are trained, is not their blame, right? They're trained to prescribe you something,
Yeah.
right? So And I feel that there is the new wave of disease, which is chronic disease. They are not medication based, right? They're more lifestyle interventions or mental health interventions, stress interventions. So I would like to contribute to that, right? And going back to your question, I think that it has evolved the way we capture data. So over time, for example, Apple has been putting more limitations in the type of data we can obtain from any kind of Apple device. So this changes, the type of results you can get, but I still believe that we're making a lot of progress in terms of how we can pass that data into a representation that actually is useful, right, in the context of health, because sometimes it's very noisy, you don't have complete data. So, this is my day-to-day problems that I have in my projects. But, I believe that we're making progress, and I believe that also will help to characterize this chronic disease and build more effective interventions. But as I said, we're early stage still, so there's still a lot more to do.
All right, great. Okay, it looks like Niusha is there on board. So Niusha, why don't we start by you sort of introducing yourself and telling me a little bit more about your background.
Thank you very much. I am Niusha. I am an associate professor and head of discipline at Australian Catholic University. I'm also the director of Women in AI in Social Good Lab. My expertise is in computational intelligence, and I have worked with both academia and industry on the applications of computational and artificial intelligence. And I'm happy to be here. But I wanted to put a background. Yesterday I fixed it. Is it possible to do it here, or we have to leave and come back again?
Oh no, we're already live.
Oh, okay.
Yeah. So we had like a fantastic discussion where Omar, Soroush, and Michael, they shared their point of views regarding the general questions that they asked upon. With that, Michael and Soroush, do you have anything to add on to like Omar's opinion or his viewpoint?
Maybe I'll just jump in and say, like, I some of your reservations around data that's currently accessible, and then maybe like data loss or blind spots along the value chain, is why I'm personally so optimistic about outpatient monitoring, but at the same time very skeptical. We're so reliant, and there's so much that we don't know at this stage. Which it's wonderful to hear about your research and all the efforts you're putting into that, because as we think of where we stand now, healthcare demand in globally, but definitely in North America, has never been higher than it is today, and it's hard to imagine a future without more sophisticated outpatient monitoring and home care in place. But from an AI perspective, there's a lot of data loss across the value chain. Apple's not capturing everything that you need it to. How does this get into the EHR? What is and isn't visible to your physician varies depending on device and application. So we're optimistic. I'm optimistic. But as a result of just everything that needs to kind of modernize in that space, we've really focused on inpatient care for the moment. So Omar, I think you're absolutely right. A lot of people doing mostly radiology, and then dipping into some stuff they can do in the EHR or EMR. But yeah, echoing that of like how big of an opportunity, but also how big of a challenge this is going to be.
Yeah, and I wanted to also point out that there are lots of good work being done in several labs, some in my lab, but outside my lab as well, on sort of integrating AI tools with mHealth applications, where you have Fitbit data being collected, Apple data being collected, all sort of data being collected outside the EHR system, and you have fantastic AI tools that can intervene without having the patient go to the hospital or go to their doctor. So we've
Yeah.
had several projects where we were successfully reducing, things like suicide rate for mental health patients, because now with their cell phone, you can predict that they're going to have, a mental health episode in a week or something, and then you can just intervene using their cell phone. So lots of additional data is being also collected, being generated, that could be added to the EHR data. And that could be very beneficial for several reasons. One is that we have, especially in rural areas where we have patients that cannot go to their physicians because they're far away. They don't afford to take a cab. It's hard. So we are bringing their doctors to their essentially home by just having their cell phones or other devices act as their physician. And then the other advantage, as I mentioned, is that when you think about how treatment policies are developed, they are all based on limited clinical trials, right? And what we learn from clinical trials are often very, very limited and very costly, right? So, but with this additional data that is being collected, we now, I think the AI has amazing opportunity to learn new treatments, to come up with better ways of improving health without having patients to go to hospitals or to their doctors, and be able to intervene when needed.
Yeah, that's right. All right. With that, Niusha, I had a question for you. So your work primarily revolves around, in computational intelligence, and that has sort of led to the creation of Ai-Labz, a predictive analysis tool. So could you share a pivotal moment in its development that illustrates its potential for, real world impact?
Yes, thank you very much. The tool, the AI tool that I created, it was created in 2019. And the reason behind it was that I saw that we need a tool that doesn't require people to learn or know about any programs and any languages. That's why we created a tool that people could click on it and analyze their data using AI algorithms. It still needs a bit of training, but in an hour or so, someone can learn how to apply AI algorithms. And this tool can be used for applications that are related to healthcare or any other AI-related applications.
All right, that's great. Do you have Soroush, Omar, or Michael? Do you have any comments or anything else that you want to add on? All right, so I think we have a couple of questions from the audience as well that they were curious about, and I'll just randomly pick one. So there's a question from Fiona that is that what are the key challenges that small and mid-sized healthcare providers face in transitioning from lab-based systems to the cloud? Would anyone like to sort of answer this question, or do they have any thoughts on this?
I'm happy to just give a
All right.
bit of perspective from our area. Very regulated environment, particularly in Canada, where in addition to some of the things that have been listed, we need to think about data sovereignty, which is an added issue if you're operating in Europe under GDPR and not hosting your health data in another area annexed in another country. So for us, and then this is where maybe like the air comes out of the balloon, we're largely on-prem. We've largely not moved robustly into a cloud environment, which has its benefits and its drawbacks. One is we don't have that sort of same hurdle rate around cloud adoption and security, but there then is this reliance on your on-premises data center and having those people, those individuals that are on site that can make sure that you can maintain and sort of keep operations flowing. This is, and maybe we'll kind of get into this is possibly cost prohibitive for the smaller centers too. Like I mentioned, we're a fairly large healthcare network in Toronto. We have 3 sites. We have the capital to maintain and grow our cluster as needed. I do foresee a point where we would like to do more in the cloud as we get into more kind of like omics works and more work in medical imaging. But currently right now, this is, with the regulatory issues, with the cost barriers, we are still on-prem.
All right, that's great. Does anyone have any follow-up comments or questions, or should I move on to the next question from our audience?
I could just add a couple of comments to what Michael just correctly mentioned from the U.S. perspective, essentially. In the U.S. also, there are similar challenges of regulation is definitely one of the main ones is because of the data privacy. Cost is definitely another thing. But there are, in the U.S., the healthcare system, as you may know, is that we have lots of different entities that are involved. So, and for anything to happen, you have to have them have incentives that align. So, for instance, for this specific question of small providers using clouds, well, there's cost, there's regulation, but you have to deal also with lots of other entities like the insurance companies, and they're having their own incentives and how they build things. And you have the EHR developers that they usually have their own requirements. So in the US, you have Epic, for instance, and or Cerner, for instance. They have their own requirement of what you can do and what you cannot do. And so if you want to make any changes, like, you have to have the incentive for them as well, and they have to follow them and follow their requirement as well, which makes it harder.
Yeah, that's true. All right. With that, I think I'll move on to the next question from our audience. So there's another question that as healthcare organizations migrate to the cloud, how can they ensure patient data security and regulatory compliance? I think you sort of got that, but yeah, that's also one of the questions that is there from our audience. Yeah,
Well,
would anyone?
I can answer. Yes, I can answer that. For data security, it's something that we really can't ever guarantee that the data, is secure on cloud, because it is still hackable. But we can try our best to put different layers of security to the data that is related to people, and especially to the identifiers that, people can be identified through those. So put more security behind those, or maybe save the identified data. So there are ways that we can increase and enhance the security measures, but honestly speaking, there is no way that we can say, okay, something on the cloud is 100% safe.
Yeah.
I absolutely agree. I want to just add something of that. Anyone who touches this, and I imagine there's some researchers that will watch this, and you're all doing your annually your researcher sort of like privacy training, and it's an ongoing process, right? Like you're going to get better the more that you do this and the more work that you put in. And some of the stuff, like I'll say, like it is first principles, but as we go and we reevaluate our applications in production, we ask ourselves, have we really thought through limiting use? Classic sort of privacy provision of that. Are there fields, are there features in this algorithm that we don't necessarily need to expose? Could we get the same performance by using less and therefore decrease kind of the privacy risk of what we're putting forward? Something that you'll see in production and maybe speaks to a bit of the gap from a research environment to really like an applied care perspective is walking away from some of the identifiers. And I imagine we'll get into like ethics and bias and some of these other assessments. But we really need to think about, is that necessary? Probably from a bias perspective, we will want to be doing some of that work. And on the other hand, you also want to kind of limit the amount of identifiers that you are exposing. So it's a bit of a balancing act of how are you making these decisions, and how are you being consultative with the constituencies that you serve. But I would say first principles really, really important. Limiting use is one of our favorite tools, and something that's actually in Epic and built into Cerner is you can use encounter number instead of someone's name or their health card number. So we just don't have to use those fields. They're not necessary. We can use a counter. We can encrypt that, and we can make it much safer than by exploiting all the data that's available to us.
Yeah. All right. Is there anyone that wants to add anything, or should I move on to the audience? The next question from our audience. All right. So I'll move on to the next question from our audience. I think it's sort of similar, but yeah, how can we make sure AI remains unbiased and fair with healthcare related decision making, especially with current biases already existing in healthcare?
I can answer that if no one else wants to. There are ways that we can manage biases. Depending on what bias is has caused the bias, so we can sometimes we can really avoid having a bias in the data. If there are biases that we can see, for example, we have collected data related to some minority groups, and we have some other data that is not related to the minority group. This is just related to other people. When we want to use this data as training data to train the AI systems, if we don't have enough minority groups data and we have a lot of other data, that causes bias in the outcome that we get through that AI system. So because this is a bias that we can see, we can come up with solutions to solve that, okay? So it can be avoided. If that kind of bias happens, it's the problem with the developer of that system. However, there are some biases that we can't see, and they're not detectable. For example, it's in the data in a way that, you collected data, but you were not aware that the data that you're collecting is biased. As a researcher, when you're conducting your research, you just talk to your friends. This is not something that we do because those are the people that we know. So if we can't, there are hidden biases, it would be very difficult to manage.
Yep. With that, does anyone have any other inputs?
Yeah, I have a few other comments.
Yeah.
So from the standpoint of equity and make systems more fair, I think that there's a lot of misconceptions on what this even means, right? Because we have in our minds this vision of equality, and I mean it's great, right? We all want that to be that case. But the reality is that it all starts with data, right? And unfortunately, we don't have the data to be to do this, right? To be to apply health equity and to do that. So what I mean is that most of the data available to me as a researcher or any other researcher is from two types of populations. One is white populations, which are the majorities, and the second one are females, right? So every time I see a paper, unless it's pretty focused on minorities or anything like that, any general paper that just investigates a general question in healthcare is majority woman, majority white, right? So right now, I think everything we're developing is for them, because if there is no data, there is nothing we can do, right? So I feel that the first step is just to educate minorities about the implications of this, because I also can't blame them, right? So, for example, Black people have been, they have all this history in the U.S., right, about the health equity and the problems that we have with racism, and they don't want to trust any of the healthcare systems because of that. And so I think it really has to go beyond this vision of health equity and more thinking about data and how can we balance those data sets in order for us to have representations of everyone, right? And an example is this Alofos data set that the NIH tried to collect from minorities. That data set, even that it was focused to do that, they just increase the representation for a few percentage, right, than any other study. So while they are trying, this is still there's a lot of barriers. So I believe we first need to educate, make sure that people trust the system, that we do what we're supposed to do, and then we can create all these ethical frameworks and ethical, systems that we all want.
I can
Yes.
add to some of the things Omar mentioned. So I'm on a national AI task force for NIH and for the US to improve the sort of reduce the biases of AI system. And some of the recommendations that we have had for the government is to engage essentially minorities in the processes of including their data sets in terms of training AI system. And so hospitals and community health systems can do a lot here. They can engage the communities. They can engage the sort of minorities so that their data becomes also representative in the training data. But from a research perspective, from a technical perspective, some of the things that I teach in my class are, for instance, ways that we can train AI system without relying on human-generated data that is by nature biased. So now we have the ability to have AI tools that they generate their own data, and then you can train AI tools on that data. And if we can do this correctly, I think here AI has an opportunity to remove the biases that are in the data sets that are representing human biases. A lot of these data sets that we have, a decision is being made by a human, right? And that human is biased, and so that therefore the data becomes biased. But if we can move towards ways of having AI generate, the data for us and generate it in an unbiased way, and then you train AI system over that generated data, right? This is where AI can actually, play a huge role for me.
All right. Yes.
I'll just before we move on, I'll make my plea of that. Some brilliant researchers listening to this, come to Canada. Toronto is one of the most diverse cities in the world, a publicly funded healthcare system. Luckily, diverse representative data sets is not our chief issue. One of our chief issues is the unseen biases that Niusha is referring to of how do you then change standard of care? How do you sort of understand that maybe that physician is treating a certain type of individual differently or prescribing a bit differently, and you wouldn't know. The other piece that I would say, like for the data scientists that are and researchers that are listening in, get to know some clinicians and get to really understand the data collection process. You might think something is informative, or you might be seeing a signal, and it may not actually be sort of really teaching you or telling you too much. One example is, like, we've had graduate students come in and feel like they really noticed something that would decrease length of stay, and merely it's just staff change or schedule change within our emergency department at around 6:30, 7 a.m. So there's things that you might be observing in the data that you think is really important, but you have no insight into clinical practice and why is it being recorded, or what is actually the collection process behind that. The other piece I'd say from a Canadian perspective, for good reason, we are regulated not to capture ethnicity. So we do have sex, we do have great representation, but we don't know if someone is Black or South Asian or Caucasian. We're regulated against collecting that information. likely because that would have been misused many times over. So what is important, and where I think the AI community and some of the work that Soroush's committee has done, and the global kind of AI movement has done, is what we've started doing with model fact sheets. Should these actually turn into kind of like your prescription label when we're pushing out systems into applied use or into production? And what I mean is that should we have this warning label or some greater level of transparency that largely this was trained or developed on a North American Caucasian audience. It was done for this period of time. It represented X amount of women, and there are these risks, there are these gaps. Should we increase by and large the amount of transparency that we're sharing with patients around the work that we're doing, so that they can be better informed of the risks and trade-offs in the care that they're receiving?
All right. Yes. I think we sort of got both the perspectives from like US and Canada with sort of this question. All right. So I think we have one last question from our audience, and that is, how is the advancement of AI influencing innovations within healthcare? I think we, of course, did discuss upon that, but there's also more to this question, saying that, and how do you anticipate this will change healthcare in the future? So looking at future prospects of, AI in healthcare. So would anyone like to sort of start, with this question?
If that's okay. Yes, I can start.
Yeah.
Well, of course, AI is changing all the industries, and healthcare is one of those industries that definitely will see a lot of changes in the future. And as Michael and Soroush and Omar mentioned, we will be able to provide healthcare for remote areas that don't have access to physical doctors. So we will get to the place that maybe physical doctors will just be guiding the AI systems, and the AI systems would help them in their decision making. So when I was talking to one of the specialists about the outcomes of one of the research that we're conducting in identifying issues with problems with lung, he was telling me that after AI came to the picture, their diagnosis has become really stronger. And I believe that this trend will continue and move on and get better and better.
Yeah.
Great points. I'm happy to jump in with sort of our more recent interests and research areas. We've published in the Canadian Medical Association Journal of a tool that we've been running since October 2020. We call it ChartWatch, and it's an early warning system. And we've observed a decrease in unintended mortality of 26% since we've implemented this tool. So astronomic change in terms of how many lives are actually being saved, so objective outcomes from our systems. I'm going to tie this back to some stuff that Niusha just said and Omar said at the beginning. Our chief area of excitement around where this is going and what this means for healthcare is, by and large, most of the advancements are in two areas. One is on using the large repository of data within the EMR or EHR, and then there's a second body of work that's happening within medical imaging. There's not much crossover between these two areas. So you're doing kind of like vision systems within medical imaging, or you're doing kind of causality, correlation type work within the EMR data. What we are chiefly excited about is how are we advancing kind of into medical multimodal AI? How are we tying in video feeds, auditory feeds, and really thinking about all the different senses that should be available for a physician when they are, coming up with a prognosis of an individual. They're looking at them, they can smell if there's alcohol in their breath, they can see if there's a subtle twitch in their in their hand. They can hear how they're speaking if there's a subtle stutter. Right now, the chief issue of Omar is this right off the beginning of we're really only looking at EMR data and there's so much that's missing. That's the part that I'm getting the most excited about when we think of the future of AI in healthcare is it's going to become multimodal and it's going to be even smarter than what we have today.
And I think, like, in addition to that, even within the EMR system, we haven't thought carefully about what AI can do to be impactful. So for instance, when you think about like how much data there is already in the EMR system, there's tons of data for any types of patient. Like these large hospitals, for any patient, we have, the ability to make the AI come up with recommendations that are fully personalized. Like for instance, we have now access to full genomic data, full genomic sequences of each patient. And traditionally, the healthcare has been always developed, like the treatment recommendations are always developed for an average patient. You look at what the physicians actually do and how they learn to come up with treatments. They all learn it based on these clinical trials, which are run, first of all, for a small subset of patients. Second of all, come up with recommendations that are completely fixed. In other words, that are developed for an average patient, which doesn't exist. We know that the average patient doesn't exist. So with this, level of data that is, as Michael mentioned, multimodal. You have clinical notes, you have genomic data nowadays, you have lots of imaging data, you have lots of clinical visits information that is there in the EHR system and has not been used traditionally. And now AI can go through them and can, fully personalize the treatments for each patient, especially using their genomic, sort of information, as opposed to right now, what we're doing is that all the treatments are, developed for an average patient, and that's not useful. And on top of that, if you can add other things that Omar and Michael and Niusha were saying, like other sorts of information that is out there, you can collect via variables, you can collect via other sensors that are available out there, and via other tools, and via cell phones. Essentially, you can add that to the EHR data. Then you have a huge amount of data that can fully be used to completely personalize treatments for each patient.
All right, so we just like to close with a dream that I have. So a personal dream in the future is that I would like to help build the first reliable primary care AI. Which is very challenging to understand even what that means. But instead of people searching on Google for what kind of problems they have, which is what they do today, and now they're using ChatGPT and all of that to upload all kind of data to figure out their symptoms or anything. What if we could build a reliable AI that could do that, right? So it sounds almost impossible, but at least it's a dream of mine because I'm from Mexico. I'm from a country that doesn't have much advanced technologies, or there is a lack of doctors, primary care doctors, here as well in the US, right? So how can we fix that problem? And I feel that step by step we could get there, right? And at least I feel that that's something that excites me and wakes me up every day. And hopefully, 10 years from now, could go back to you guys, say where we are. But yeah, it is very interesting. And I feel that we're making progress, right? So I think that even though we don't have much progress today in terms of clinical decision making tools, I think that's going to change, and hopefully that will help us address the challenges that we have today, which by the day they're getting worse. So for us, it's a challenge that we have to more or less keep thinking about how to be more innovative and impactful, because we're actually not doing better than yesterday. We're doing worse instead of health outcomes. So it's a homework that we as researchers and patients and everyone has to think about how to change, right, and how to have an impact. But yeah, that's at least the future of healthcare AI that I would like to build, and hopefully to also contribute to our society, right?
All right. Yeah. Thank you so much, Omar, for your closing sort of statement. And we hope your dream sort of comes true, and then we wish you the best of luck for that. And then with that, does anyone else have any last closing arguments or closing comments that they want to sort of give? All right. Okay. With that, thank you for joining our event, and we hope you had a great conversation. And thank you to all our speakers for joining us today and giving us your insights on AI and healthcare, specifically on ethical biases, new innovations, and also the future of AI and healthcare. And thank you to our audience for your questions, and we hope you had a great time listening to our conversation. I know I definitely did. And with that, have a nice day and bye.
Thank you.
Thank
Yeah.
you.